Hello, holistic. Our topic today will be about regenerative injection therapies. I would like to quote Dr. George Hackett, the founder of Prolotherapy. Uh, what he's saying here is a joint is only as strong as its weakest ligament. George Hackett, one of the founders of this science. He was a trauma surgeon, and he developed a technique to regenerate the musculoskeletal problems through injecting something called prolotherapy. Regenerative injection therapies, by definition, is the rehabilitation of an incompetent structure, such as a ligament or tendon, by the induced proliferation of new cells. Regenerative injection therapies could be done through different ways. I just mentioned the important ones. And I know this slide is kind of congested, but it's important to understand what are you using. So you can stimulate regeneration by injecting osmotic agents such as dextrose. Now, in old days, we used to use other agents like pumice, uh, sodium morowate, and others. And I'm sure there are still practitioners that are still using these kind of agents. But for safety purposes, I would advise against these agents unless you're really very professional, in these injections. Growth factors, the most famous ones are the platelet-rich plasma and stem cell. And these are basically the most important ones available nowadays. Oxidative stress regulator, Prolozone using ozone. This is also a cheap method to do, regenerative injection therapy, but there are a lot of, controversy about condom protection using hyaluronic acid is also very famous, but still there are controversy about it. Could be useful in early cases. Neuromodulation using dextrose 5%, such as perineural injection therapy, deep nerve hydrodissection, sweet caudal. All of these can be done through dextrose 5%, which is readily available in every hospital. And it basically downregulates TRPV1, or what we call vanilloid receptors. Peripheral nerve generation has been also done through platelet-rich plasma. And even trigger point injections has been studied using dextrose 5%, which showed superiority to our regular lidocaine or saline injections. 3 stages of healing: inflammatory, proliferative, and remodeling. First, you increase you do the inflammatory, basically part here, which increases the blood flow. It might cause some swelling and pain might increase. Then there are immune cells such as macrophages, will remove the damaged tissue. And usually this is, the earliest response. It's an immediate response that occurs in the first week, followed by the proliferative phase, where you start to form new blood vessels. You start to recruit immune cells, such as fibroblasts, which form new collagen. And usually this proliferative phase lasts for 6 weeks. And then lastly is the remodeling, through new blood vessels, increased density and diameter of the collagen fibers. And this one actually continues from day 42 until 18 months after injury. Again, this picture show you, the stages of healing, inflammation, proliferation, and then remodel. George Hackett has done a bunch of animal studies uh, in rabbits' tendons, where he showed injecting these proliferant agents can actually cause marked increase in the bone attachment of the tendon, marked increase in the soft tissue, strong fiber osseous union, increase of the tendon diameter by 40%, and the attachment of the ligament to the bone has increased up to 30%. So this is really amazing, because this is actually the only technique that can increase the strength of your tendons and ligaments, which is really uh, opposite to the muscles, has very few blood vessels around. Types of collagen, we have 5 types. Type 1 is the one that we see in the bone, tendon, skin, and dentin. Type 2 in cartilage. Type 3 in blood vessels. Type 4 in the basement membrane and basal lamina. Type 5 is in the placenta. Stem cell therapy. Again, I want to give you an idea about these non-embryonic stem cell regenerative injection therapies. Often patients and clinicians tend to think of stem cells being controversial. However, that relates primarily to the early days when stem cells was synonymous with the use of embryonic cells, totipotent or pluripotent stem cells. In the clinical context of modern regenerative medicine, stem cell therapy uses non-embryonic somatic cells. Most of these cells are described in the context of multipotent stem cells and often in clinical settings referred to mesenchymal stem cells or hemopoietic stem cells. So this is a stem cell. It's a mesenchymal stem cell. It's a primitive cell which has the ability to self-replicate, differentiate into multiple tissues, fight apoptosis, and reduce inflammation. We can obtain the stem cells through the fat in your belly, or you can retrieve it from the bone marrow, basically from the PSIS. So again, this show you a picture of the totipotent, pluripotent, and multipotent stem cells. We are using this one, okay? Not this or that one. We're using the multipotent stem cell. Stem cell types. The main three types are adult multipotent stem cells, or bone marrow aspirate concentrate, as we mentioned, or adipose tissue grafts. So these are the three main sources for the stem cells as far as we're concerned. Platelet-rich plasma is a very important subject as well. Platelet-rich plasma contains growth factors such as platelet-derived growth factor, transforming growth factor, insulin-like growth factor, epidermal growth factor, vascular endothelial growth factor, the VEGF, fibroblast growth factor, and connective tissue growth factor. These growth factors interfere with the catabolic microenvironment in osteoarthritic patients, modulating the inflammatory response, inducing cell migration and proliferation, and regulating the angiogenesis and cell differentiation, so promoting and accelerating healing of hard and soft tissue. Evidence-based medicine. Basically, PRP is useful in scenarios such as patellar tendinosis, lateral epicondylitis, early knee osteoarthritis, and athletes with high ankle sprains or muscle strain grade 1 and 2. There is no role or clear role in rotator cuff partial tear and Achilles tendonitis. Leukocyte-rich plasma has more inflammatory and useful in muscle and tendon injury. Leukocyte-poor plasma less inflammatory and useful in avascular structures such as joints and discs. This is how we prepare the platelet-rich plasma. We basically prepare it from the patient blood, and we put it in a certain centrifuge machine, and then this will separate the blood into plasma and red blood cells, and then you have the white blood cells and platelets in this area, and then you pull them out with your needle. FDA compliance. The cells should be the patient's own, so you really cannot use PRP from another patient or from another person. Cells must be used in the same surgical procedure. So if I'm pulling the blood today, I have to, get the job done in the same setting. Cells may only undergo minimal manipulation in the cell processing steps. The cell's biological function must be identical between the harvest and delivery sites, or what we call homologous fusion. I'm just going to show you some articles from the PubMed around PRP. Like this one is important. Interarticular PRP versus interarticular steroid for symptomatic management of knee osteoarthritis. And the conclusion actually was interarticular PRP injections produce superior outcomes when compared to corticosteroid injection for symptomatic management of knee osteoarthritis. Platelet-rich plasma versus hyaluronic acid in the treatment of knee osteoarthritis. Well, interarticular PRP injection appeared to be more efficacious than hyaluronic acid injection for the treatment of knee osteoarthritis in the terms of short-term functional recovery. So, in the last two articles here, the interarticular PRP is superior to corticosteroids and hyaluronic acid in knee osteoarthritis. Another article here, plasma therapy for peripheral nerve regeneration. So this is a new kind of a concept, is that you use this PRP to rehabilitate your nerve, not only the musculoskeletal system, and also regenerate the peripheral nerves. These are a bunch of evidence, about these, concept. Like, for example, here it's been used in carpal tunnel. It's been used in radial nerve injury, peroneal nerve injury, peripheral neuropathy. Okay, we're gonna jump into a new concept called the Baton score. Okay, which is basically a score that predicts hypermobility syndrome. And this score is composed of 9 points, 1 point on each hand, 1 point elbow, uh, 1 point for putting your hands flat on the floor with your knees straight. Um, Now, if you score more than 5, you probably have hypermobility syndrome. The commonest one is what we call congenital hypermobility that we see in young adolescents. And it's not very serious, but we have more serious, problems like Marfan and EDS, or Ehlers-Danlos syndrome. So again, Beaton score, very useful score to predict hypermobility syndrome. Looking at, bending the thumb to your forearm, bending your knee backward, bending your elbow backward, and bending your little finger up to 90 degrees to the back of your hand, and placing your hands flat on the floor. Above 5 predicts hypermobility. So first, we'll talk about the benign joint hypermobility syndrome, which is pretty common. It affects 10 to 15% of children and adolescents. And these patients, in general, they usually suffer from, musculoskeletal injuries. And they usually show up in the, doctor, either pain doctor or sports medicine doctor, even just the regular internist with these type of injuries. Okay, osteoarthritis. I mean, seemingly it's almost like, opposite to the hypermobility syndrome, but still PRP works on it because it helps with the damage that happens with osteoarthritis. With osteoarthritis, usually it's in patients above 60 years. Female to male ratio is 2 to 1. And basically the leading cause of disability in the United States. There are 2 causes of osteoarthritis. Primary, which is basically an aging and mechanical stress associated with genetic component, and secondary, related to obesity, acute trauma, surgery, gout, and other diseases as well. Kelly-Lawrence grading scale is important scale from grade 1 to 4. The grade 4 is basically what we call bone and bone. Okay, and this stage usually do not respond to PRP. The stages from 1 to 3 are basically, the ones that respond to the PRP because there's still, cartilage available that you're targeting here with your PRP. But in stage 4, usually we, proceed with radiofrequency ablation. Again, some of the physical and chemical forces that alters chondrocyte function, like doing arthroscopy, steroid injection, NSAIDs, all of these reduce the healing power of, the cartilage. Hackett has a very nice referral pattern, uh, you know, uh, diagram. And I just wanted to mention that some of these ligamentous and ligamentous laxities here can show up like a sciatica pain, can show up as a groin pain. For example, this iliolumbar ligament, you know, uh, iliolumbar ligament can show up as a groin pain. So you have to really understand that not everything you see is necessarily related to a nerve injury. It could be ligamentous flex, and this makes it more challenging. When you treat any of these patients with low back pain and radiating to the lower extremity, that you have to really think about, a differential diagnosis here. One of the most famous ones that we do is the sacroiliac joint, and I came out with, a program for the sacroiliac back, like 20 years back, uh, using first of all, I call it the 5D program. First, check for false versus true leg discrepancy. If you have a true leg discrepancy, you're probably gonna need a heel lift. Then you do the Dom technique exercises, okay, which are basically exercises that targeting the sacroiliac joint. Then you do the dextrose injection, or right now we do more of the PRP. Then you use a belt, sacroiliac belt. One of the famous ones is called the Don Joy sacroiliac belt. And then deactivation of the trigger points like the piriformis, quadratus lumborum, and so forth. So this one is a test for leg discrepancy. If it's a false leg discrepancy, you don't need a heel lift. With false leg discrepancy, you need to correct the sacroiliac joint. You need to put it back in place. But with true leg discrepancy, you're going to need a heel lift. Don Tigny exercises, and Don Tigny is a famous physical therapist that passed away a few years back. And this guy spent, more than 40 years of his life, devoted to the sacroiliac joint. And he has very nice exercises that you can retrieve from this website, thelowback.com. Dextrose injections, you can do it blindly or you can do it under x-ray. Nowadays, of course, we do everything under fluoroscopy. But in old days, we used to do it in the clinic, and still some practitioners do that. In my mind, is uh, to do it blindly or under without X-ray. You have to really do a lot of injection, okay, to make sure that you really covered all the areas needed. But with actually with fluoroscopy, you are more targeted, and it becomes less painful to the patient. You can also inject the Z joints or the facet joints, supraspinous and interspinous ligaments, especially in situations like spondylolisthesis. This is thoracic Z joint injections. And again, we used to do it blindly. Nowadays, we do it under fluoroscopy. For to reduce the complication rate here. Now, with the new agents, you really don't get a complication from the agent itself. You get a complications from the trauma of the needles. But in old days, when George Hackett started, they used stuff like zinc sulfate. So, I mean, of course, this is pretty serious. If it gets intrathecally, you will get, chemical acrylitis. It's pretty serious. We do not do this anymore. Stuff like pumice, sodium borate, and other. There's another one called Ongli solution. But all of these, they're very irritant, and you need a lot of expertise. So you do not get these material inside your uh, intrathecal sac. Hackett for cervical pain, Hackett referral pattern for cervical pain. And it can look like you're having a headache, and all you have actually is some ligamentous laxity in your neck here. And this is just some of the cervical facet injections that we do after, especially after whiplash injuries. The commonest two facets involved in the neck are C23 and C56. Now, there are a lot of research on the upper cervical stability and how this interacts with many of the nerves in the neck area and how it affects your body in general. I mean, you can look at this. You can actually, with the cervical, upper cervical stability, you can get carotid sheath compression, and this could, affect your spinal accessory, glossopharyngeal, vagus nerve, and so forth. This also can affect your cervical trigeminal nucleus, interrupt the CSF flow, um, you know, uh, increase your cervical spinal cord tension, can lead to POTS. So, I mean, just, because the neck basically is just, an area where all the nerves and blood vessels get to the brain, coming into the brain, coming out of the brain. So just imagine that you have an unstable, cervical spine. This will affect all these nerves coming in and coming out of your brain here, and the vessels, the nerves and the vessels. And so, really injecting, stuff like dextrose to reduce this instability could be very helpful to a lot of patients. One of these manifestations of cervical instability is a syndrome called Barré-Roux syndrome. You would not hear about this syndrome except in the setting of prolotherapy meetings and all that. And this is not part of the, IHS or International Headache Society classification at all. Okay. Um, I've seen it, once, but every once in a while I get pictures like, with these kind of syndromes, and maybe not the whole, criteria, but it will always remind me with the instability in the cervical area. Okay, how about this degeneration? Well, we have some literature about injecting the disc with, with proliferant agents, okay? Different proliferant agents. Still, the research is in the beginning here, all right? And even ozone has been injected in the discs. Temporomandibular joint. This is one of my favorite areas. Uh, and I found that this is, you know, very useful in patients with TMJ issues. And I love to use the ultrasound in these injections. Trying to do it with X-ray is pretty difficult. Under ultrasound, it's straightforward. Shoulder injections, as you can see, this is a comprehensive shoulder prolotherapy treatment. The prolotherapists, or the ones that inject dextrose, okay, PRP, prolotherapy is under the umbrella of regenerative injection therapies. And usually when these doctors inject, they try to do a comprehensive injection here, not just one side. They do the whole shoulder, even if the problem is only one side. They try to inject the whole thing, so they strengthen the whole, ligaments and tendons in this territory. Upper extremity injections here, lateral epicondylitis, what we call tennis elbow. Here, medial epicondylitis, what we call golfer's elbow. In the hand, in the carpometacarpal in the thumb. Also, I've done few of these where patients present with symphysis pubis injury and a pain, and usually this area, there's a laxity of the symphysis pubis, and you just inject the ligaments, and it's pretty straightforward under fluoroscopy. It doesn't take a minute to identify it and inject. Once you touch the symphysis pubis, just infiltrate your injectant, whether it's a PRP or dextrose or whatever. The hip joint also, again, I want to mention that prolotherapists, adopt the comprehensive technique for injecting the joints. So here in this picture, and this is out of the journal of prolotherapy.com. They have very nice pictures for different injections. If you look here, you can see the results of injecting these agents in the cartilage. There's cartilage repair here, as you can see. This is before and this is after. Knee joint injections, the same. We do a comprehensive injections in the knee. And you can see before and after prolotherapy. This area has widened up. In ankle injections, especially plantar fasciitis and Achilles tendonitis, we do a lot of these prolotherapy. And you can see the improvement of the ankle x-rays after stem cell prolotherapy. So prolotherapy, as I said, is one type of regenerative injection therapies that's done with dextrose. Okay. Prolotherapy is done with more than 10% dextrose. Okay. And it's mainly indicated for ligamentous laxity, tendinosis, hypermobility, and osteoarthritis or osteoarthrosis. We bring this dextrose 50% and we dilute it with water and lighting to 12.5 or 15%, and we inject it in different areas. Now, dextrose can be also used as a neuromodulator. So remember we talked about injecting the nerves, so rehabilitation of the nerve. Okay, and this is done with a 5% dextrose. You can do perineural injection therapies. You can do sweet caudal. You can do deep nerve hydrodissection, like for example, the lateral femorocutaneous nerve for myalgia paresthetica, and you can even do trigger point injections with the same solution. So what I do is I bring this bag, 5% dextrose bag. I add just a small amount of bicarb, okay, to buffer the solution. And then I use this bag the whole day, okay, for my patients. And then at the end of the day, I throw it away. Liftoff is the one that taught us how to do these perineural injection therapies. And you can see the guy here in the picture. And he described the mechanism either by decompression of the nerve or downregulating what we call the vanilloid receptors. So decompressing the superficial nerves occurs by injecting the material in the subcutaneous area. You relieve this zone of injury called the chronic constriction injury. And in this picture, it modulates or downregulates the TRPV1 or the vanilloid receptors that help with reducing the pain through the C fibers. This is how it looks like. Basically, Liftoff has developed this technique based on knowing the anatomy of these peripheral nerves. So most of his work is injecting these areas related to these nerves around the shoulder, the hip, the knee, and so forth. He uses dextrose 5%, buffered dextrose 5%. Now, the deep nerve hydrodissection is a little bit different concept because you go deep to inject the D5W. With the perineural injection therapies is done in the subcutaneous area, but with this one, you go deep, and like for example, you can do it under ultrasound guidance. You can do, for example, the atrial or you can inject the carpal tunnel with dextrose. Number one, this down regulates by decompression of the nerve, freeing the nerve from all these adhesions around it, and also it down regulates the TRPV1. Now, I like to do this a lot, the sweet caudal, especially in diabetic patients that I don't have a choice of injecting steroids. Brittle diabetics, I like to do the sweet caudal. And I do it again with a buffered 5%, dextrose 5%. You can do it even blindly. I mean, you will never hurt anyone except with, if you're with the needle itself, you can injure sensitive areas, but generally speaking, it's pretty safe. Trigger points can be also done with D5W. And I want to say that I've done it in many patients, especially the one that either having allergic reaction to local anesthetics or the ones that have sensitivity to local anesthetics in general, like patients with MS, for example, multiple sclerosis. When you do this injection, you relieve them, you basically break this muscle spasm cycle, which reduces the energy crisis that's happening in the muscle related to, reduced blood flow. Okay, another nice topic is Prolozone. And I want to say Prolozone is controversial, okay? So we don't have a lot of robust evidence about it. However, there are still a lot of people using it. That's why I brought it in my presentation here. With ozone, you can do trigger point injections. You can inject the disc, you can inject the joints, and you can do interforaminal ozone. And this is a machine that most of us use. It's from a company called Longevity. Um, so I want to mention here a couple of articles about injecting ozone intradiscal and also interforaminal. Ozone discectomy. Now, ozone works by different ways. It has an antimicrobial effect. It activates aerobic process like glycolysis. It helps with secretion of vasodilators, such as nitric oxide. It induces the synthesis of interleukins and leukotrienes, expression of adaptive inflammatory process. This is a comparison between PRP, Prolozone, and Prolotherapy. As you see, with PRP, you need only 1 to 3 sessions. With Prolozone, you probably need more, and also same thing with Prolotherapy, which basically tells you that probably PRP is the most effective of these techniques here. How about hyaluronic acid? Well, this was developed by Dr. Carl Mayer. And I like to use hyaluronic acid, especially in the early cases of osteoarthritis. Um, Now, there is a problem with these hyaluronic acid. It can actually cause allergic reaction. So they having a new type of hyaluronic acid that's derived from biologic fermentation and doesn't have this problem. Um, the references basically I put them here. Please, take a note of them. Each of these references will help you out understand, better prolotherapy and, proliferative injection therapies. Thank you. With Let me just review the key learning points here. Um, Prolotherapy is a joint stabilization through induced tissue sclerosis. Commonest agent used is dextrose in concentrations above 10%. Dextrose 5% is used in nerve rehabilitation such as perineural injection therapy and others. Prolozone is one method to use ozone for induced proliferation. PRP and stem cells are gradually replacing dextrose, RIT, or regenerative injection. Therapies still need more robust randomized studies for proven efficacy. And I want to end my presentation with this slide here. I love it. Regenerative injection therapy completes what your body started. In other words, it helps with the healing of, your body. Thank you, guys.